You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Dr. Robin Bannister, the founder, Director of Research and Development at the Care Oncology Clinic. Very unique clinic that we'll get into. I just want to do this really brief intro and then welcome, Robin. Thank you for coming.
Hi, Richard. No problem.
Yeah. If you don't mind, tell listeners, what is the Care Oncology Clinic? What's the mission? What's it about?
Okay. Thanks, Richard. There are lots of reasons why people start companies, and Care Oncology Clinic was not my first, but it's the one of which I'm most proud. I started the clinic with my colleague, Gregory Stoloff. My reason for wanting to start the company was a very simple one, actually, and a very personal one. My wife had cancer. She had breast cancer, misdiagnosed, and then finally correctly diagnosed in 2005. She became metastatic in 2010. And so there I am. You know, I'm a scientist. I work with drugs. I can read papers. I understand statistics. I can see survival tables. I can see all the data. You know, drugs is what I do for a living, really. And so my wife's metastatic disease and the organs affected gave her a runway of about 2 years. She probably wouldn't even have seen her 50th birthday.
Right.
So what was I to do? You know, it's simple, I suppose. All my professional life, I've been spending that with drugs, and the last 25 of those looking at old drugs and trying to understand their true nature and how the biology and science we now understand can be used to repurpose those drugs to better effect. And so in my case, I guess there was no time. My wife didn't have time. I had no time. We needed to do something now. And that was way back. And so that was really the germ behind starting Care Oncology Clinic, you know, a personal thing, really. You said you looked at old drugs, but I would guess that most people's view is that we need a new drug. It's never a look at the old. Why in your career did you look at old drugs? It seems different to me. Yeah, that's really interesting, isn't it? That, you know, we rarely know what a drug does until it really gets onto the market. If you ask most people how many drugs are there, they'll say, well, actually, you know, I think I can think of 100 or something like that, they may say. And that is just way, way, way underestimating what the pharmacopoeia really is. There are some 5,000 materials, maybe 7,000, if you want to count them a different way, to outline what the existing pharmacopoeia is. And we really don't know what these drugs do until we get them into the marketplace, if you like, into patients, and we can start to understand what they really do, and then find out where they might truly be positioned in treatment. Aspirin is probably one of the best known of these sorts of drugs, I suppose. First used by the Egyptians, it might be, over 2,000 years ago, chewing acacia bark and getting some relief from arthritis in that manner. And then I suppose as a modern drug, it was really only considered, well, it's actually just over 120 years old now. And I suppose in the last 30, 40 years, we know its platelet activity. Today, we're only starting to understand its potential use in cancer even. And that information goes back sort of 50, 70 years. And it's understanding what drugs really do that's important. And I think we can do that so much better with old drugs. And so many of these have been repurposed. today. In the particular area of cancer, I think there's a tremendous opportunity for us, and that's why we set up Care Oncology Clinic. In part, I suppose it was about not having enough time to invent new drugs, but understanding that there were many, many old drugs that had a part to play.
Yeah, that's an interesting insight. Is there a way that, you can, I guess, hear anecdotal results? Let's say you're a clinician and you prescribe certain drugs and you've seen their effects in thousands of people over the years. That's like a pretty powerful anecdotal summary, but is there a way to get actual data? Does anyone keep data on the effects of drugs that are out there? We could look at it in a huge range.
Absolutely they do. The amount of data that's freely available to everybody to try and understand what drugs do is absolutely enormous. It's becoming greater every year, of course. And it's free for people to inspect and to sort of understand. In my own case, I was obviously interested in drugs to treat cancer for my wife. And what I was looking at here was to try and develop a strategy, really, of trying to work my way through all of that data on those sort of 5,000 or so materials that could be used. When I thought about it, I didn't really want to try and find a new cytotoxic drug. These are the sort of generally toxic drugs that we use to preferentially kill cancer cells. All the patients will be very well familiar with these, killing cancer cells and shrinking tumors. I didn't expect to find that sort of drug in the pharmacopoeia easily, because they would stick out so clearly in the data. And having seen all the sort of terrible side effects that such drugs can give, and the chemotherapy that my wife had, I was in no hurry to try and find additional cytotoxic drugs. But when I was doing my general reading in that area, I became aware that there are a lot of drugs that, although not really generally toxic to cancer cells on their own, nevertheless appear to have some activity in cancer, either through preclinical information, so that's animals and cells and test tubes and so on, or cellular stuff, all at the anecdotal level. But when I really got into it, I was absolutely surprised by what I found. Many of the drugs seem to act upon metabolic pathways that were either unique to cancer cells or heavily preferred by them. So this led me directly into something that really hugely surprised me, and it was the best known of these metabolic processes is the Warburg effect. Maybe lots of your listeners will have heard of this now. It's become something that people can start to talk about, but it was an observation made by Otto Warburg in the early 1920s, for which he eventually won the Nobel Prize in 1931. And what he did was, well, in his own words, he said the prime cause of cancer is the replacement of respiration of oxygen in normal body cells by the fermentation of sugar. That's what he described as the unique metabolism of cancer cells. But today, almost 100 years later, we'd use a much wider explanation about the unique metabolic changes in cancer cells. But the sentiment's still the same, as Otto Warburg's work.
But the question here,
say?
How do you know that a drug that's not even intended, let's say, to affect cancer would affect cancer? From what I understand, one of the drugs that you may work with is like a deworming agent. If someone gets worms, how would anyone make the connection between that and a cancer-fighting ability of it?
Yeah. So the fundamental principles behind our protocol is that the protocol drugs all affect the metabolic and related processes in cancer cells. This is what lots of people have since described as the sort of Achilles heel of cancer, that these are the unique or much preferred metabolic processes of cancer cells that separate them from normal cells. And when people talk about this as being, and you can see papers entitled things like metabolism, the Achilles heel of cancer, that all sounds a bit sensationalist, sort of overhyping it. But in reality, I think it's correct. I think Warburg was correct, and that metabolism has a key part to play in cancer therapy today. In fact, we even talk about metabolic treatments in cancer and hold conferences on that topic today. It's interesting to think about it, actually. If you think about what Warburg was saying, and remember that's over 100 years old, in it as a concept, it's a concept that's older than chemotherapy, radiotherapy, hormone therapy, and immunotherapy. The actually only cancer therapy that is older in conceptual terms than metabolic treatment of cancer is that of surgery. That's a really sort of chilling thought. And there's a really excellent book available on this topic by Travis Christofferson entitled Tripping Over the Truth. It really tells the history from Warburg's initial discovery on and up and to where we get to today. So it's these metabolic changes that we target with the drugs. The vast amount of literature behind all of these describes these at cellular levels in animal tissues, excised human tissues, small clinical studies, and indeed very large epidemiological studies. And it's putting that entire jigsaw together that allows us to say, actually potentially putting a protocol together like we've got, where we can impact different aspects of these unique metabolic processes, can potentially have a part to play in cancer. But of course,
so at this point, was the hallmarks of cancer paper out yet? They read about 2000, or was this before this?
Yeah, so that's a relatively recent thing, I think. Really, people have been aware of metabolic changes in cancer for generations. It seems almost, of which I think metabolic processes underlying cancer is one, as well as the genetic changes that people talk about as well.
So what was your thought process then? You knew Otto Warburg's work. Was that enough to get you going and searching, or how did things proceed from there with you mentally?
Yeah. So armed with that, it was, I suppose, relatively straightforward detective task for me to start to evaluate and to look at the sort of drugs we might want to use, made easier actually by the great blossoming of the range of drugs that have been developed over the last 50 to 70 years or so. That goes to generate all this sort of 5,000, 7,000 pharmacopoeia drugs. You see, these were the materials that were used in many of the investigations, those preclinical things, those test tubes, the animals and human clinical studies that went to elucidate Warburg's hypothesis. And of course, these then go on further to explore mechanisms that were not available to Warburg. So, for example, we now know that many cancer cells protect themselves through efflux pumps. That is, that they pump out the very chemo drugs designed to kill them. But this requires an energy source, Warburg, not only to make these pumps, but also to operate them. So limiting the energy sources inside a cancer cell reduces its ability to defend itself through these sorts of mechanisms, through these efflux pumps. And again, cancer cells are adept at repairing their own DNA. It's been damaged by the radiotherapy or chemotherapies. But to make the materials responsible for that repair requires an energy source for their manufacture inside the cancer cell, and then to use them inside the cancer cell. So again, limiting the cancer cell's access to the materials it needs to make these enzymes and function on these processes makes them more susceptible to the challenges that the cancer cell finds itself in. And that's the basis of the treatment, really.
So, okay. So this was your thinking. How many drugs did you have to review to find the ones that you're looking for? I mean,
yeah. So
all 5,000 must have been a good story, but I don't know, how many was it?
Life's not quite that long, Richard, but you need a way of reducing that number down to a manageable kind of size. But it's worth remembering then what you're trying to do in a cancer patient and how a cancer patient presents. They are in a situation where they're no doubt getting a standard of care treatment that involves a lot of side effects that go with that, wherever it comes from, whatever type of standard of care. That's a hallmark of it seems. And then there's the changes in the disease itself, and then there's the drugs that are used to ameliorate the side effects of the primary treatment. and yet more drugs to deal with the side effects of the drugs dealing with the side effects of the treatment. So a cancer patient represents a very, very sensitive situation. You can't just go using drugs willy-nilly. And so that safety was absolutely paramount to us. And when we considered the sort of drugs that we wanted to use drugs that had a long history of safe use. And that safe use should include being in cancer patients, for their primary outcomes, like the worming tablet that you spoke of, or the anti-infective agent, or the diabetes or anti-cholesterol agents. They're all used in cancer patients. And we wanted to have to be able to use these drugs within their existing and historical dosing regime, such that we could rely to some extent upon the tremendous history of safety of the medicines. So that was the one of the screens, if you like. How many medicines were there that were very readily prescribed to cancer patients? You could have lots of mechanistic and supporting data throughout all of those studies that I described to you, from animals and tissues up to small clinical studies. So then when we went through the pharmacopoeia, looking for those, and that they must also impact Warburg type processes, these underlying metabolic processes, we very readily came down to a short list where we thought there would be mechanistic overlap between them, synergy between them, safety in their use and their historical use, and a vast amount of scientific data and pharmacological data to support their use. And that took us quite a while to get down to that, but it certainly wasn't going through the 5,000 once we applied that kind of screen.
Right. And typically, well, nowadays, would the ideal goal to have a patient use this cocktail first before they go to the normal triad of surgery and radiation and chemo, or can it only be used as an adjunct? I mean, what's the status of it?
So what these drugs do, and this is what the data certainly supports, what these drugs do is make it very difficult for a cancer cell to survive in an hostile environment. That hostile environment is, of course, one that we would immediately think of, well, that means chemotherapy and radiotherapy and hormone therapy and immunotherapy, doesn't it? Yes, of course it does mean that. But also it means that in the presence of one's own immune system. The fact that most of us remain cancer-free for most of our lives is down to our immune system. We get precancerous cells all the time that our immune system clears out. And there's a lot of data to support that these drugs appear to have functionality to support the immune system as well. But in the context of what we're trying to do, where patients have already got cancer, the threat that the threat to the cancer cells is from those primary standard of care treatments. But in order to have their adjunctive effect, of course, they have to be on board with the patients while they're receiving their primary treatments. Because they're so low side effect and so well tolerated, what I'd really like to happen is that patients could be on these drugs almost on a sort of pre-diagnosis state. When people would go to their doctor and the doctor says, yeah, that lump looks a bit suspicious, I would like to send you to the oncologist. Maybe in the future we can get to a situation where people could be treated with these drugs as a potential prior to getting their standard of care first treatment. But what happens today in our clinic, for example, is people are diagnosed with cancer. They then come and find us, and then part way through their primary treatments, they adopt the protocol. But it would be far better to adopt the protocol, in my view, at the earliest possible stage.
Do people tend to come to you after they've gone through and been damaged and tired out by the normal protocols, or how do people find you, and what's a typical patient have in their mind, and why they would go to your clinic and not just stick with traditional stuff?
Yeah. So when a patient's diagnosed with cancer, and you see this all the time when you talk to them, when a patient's diagnosed with cancer, pretty quickly their life is taken over by the whole thing, the shock, the fear perhaps, and then the treatments and the processes that they have to go through for standard of care. They have a flood of information. Some of it seems barely understood, and all of it demands that they make some decisions. It's a very, very turbulent time for patients. They rapidly become very well informed, or many of them do, and quickly know more about their conditions and their treatments and their prospects than many of the healthcare professionals, I think. And I fully understand that these patients then look around and say, well, what else can I do? Because they can inspect the survival tables that are so readily published as well as anybody else. And so they do look around, and that's when patients will find us. That's generally how they will present to us, because they become kind of experts relatively quickly, I think, and then look for what else can I do to maximize my chances. And indeed, I suppose that was the situation that my wife and I were in.
When patients do find you, what do they say? I want to go with you, and I'm not doing the traditional treatments, or I don't know what to do. I'm going to try everything I can. Yeah. What's the typical response?
Yeah. Some people do say they're not going to try the typical treatments. That's not what we encourage, actually. Standard of care, that's one of those urban myths, isn't it? That standard of care is ineffective and has failed. That can be quite a popular view, but it's not our view. We do understand they're not perfect. And we do understand that there are refinements to identify responders and so on. But in the vast majority of cases, standard of care has a part to play. And that's why what we do is to focus our attention on trying to make standard of care as effective as possible by adding an adjunctive arm to their treatment through the care oncology protocol. But most people, I think, are looking to say, well, what can I do to add to my standard of care? Our key feature is, of course, that you can do lots to add to your standard of care, and people add all sorts of supplements and additional therapies and treatments and so on and so forth. But to go back to one of my previous points about cancer patients being in a sensitive situation, we believe having a medical oversight of the protocol, such that adjustments can be made in the changing circumstances that a patient finds her or himself in, is the proper way of dealing with that. But mostly it's patients undergoing standard of care, wanting to find additional ways of helping themselves, I think.
Yeah, it's a tough environment because you're scared, you're depressed, you feel like you're going to die, which in a lot of cases people are. And then you have people talking about natural cures versus standard of care, and maybe them calling each other quacks, and it's just a very confusing, difficult environment.
Yeah, it's a hugely difficult thing, and there's a pile of information available to people all the time on this, and there are always people that are hungry for so much information to try and help themselves, and there's a vast amount of information for people to try and find their way through. One of the things I'm very well aware of is some of the other urban myths, if you like. When people are faced with this sort of information, they'll actually say things like, well, let's just use supplements, with a belief that supplements are always safe. Just because you can buy something on the corner store at CVS, in my view, doesn't always mean it's safe. Certainly not in the complex situation of a cancer patient. If a cancer patient is expecting a supplement to have a biological effect in terms of killing cancer cells, then it's entirely reasonable that it will also have a broader set of effects, and that these may emerge as side effects. And some patients come to us with a very long list of supplements, many of which will have a biological activity, both good and bad, in a cancer sense. It's just impossible to know absolutely in those situations.
Not only that, from what I've recently learned about generic versus brand name drugs and supplements, how do you even know that what you're taking is what's purported to be on the label for medical drugs and for supplements? How do you deal with that, by the way?
Absolutely the case. It's obviously a bigger issue in terms of supplements. All of our drugs are FDA, MHRA approved. They come from reputable suppliers of generics that are used throughout the world, actually. very successfully. So they're managed through our drugs are all managed through the highly regulated pharmaceutical systems in place in all of the countries where they're used. So we can be pretty confident, as confident as we can be, that what's in the package is indeed what's on the label. And that's certainly the way that things are managed through the FDA.
Yeah, like I've seen on Amazon, for instance, at least supplements have, in some cases, hundreds or thousands of reviews, a particular one, but there is no such thing for brand name versus generic drugs, at least for the public. So
No, that's right. You really are relying upon the skills and the regulation and the authority of the FDA in the US and the regulating bodies around the world in their own jurisdictions to manage the quality of these drugs. And by and large, that's pretty good, actually, I think. Yes, we do see stories come up about manufacturers in certain countries, but they're stories that are being found out, aren't they? And things are being done. They're being shut down and they're being taken off the shelves and so on. I'm pleased to say that none of those affect our drugs.
Oh, good. Yeah. So what are you able to work with people that have any kind of cancer and at any stage, or what are the criteria by which you can help someone?
Sure. That's one of the founding principles of our protocol, is all to do with the Warburg effect. And remember what he was saying was one of the hallmarks of cancer is its change in oxidative respiration to fermentation. That's oxidative respiration to glycolysis in the modern language, and all of the things that flow from that, and now more widely considered the metabolic processes in cancer that are separate and different to normal cells, but they are common to all cancer cells. So in that sense, and this is the way that we've set up our clinic and our studies, is that we are providing an adjunctive treatment to all cancer types, because Warburg underpins, or metabolism underpins, changes in all cancer types, regardless of its tissue of origin. So that's the first point. First point is, we think this is relevant to all cancer types, regardless of if that being a solid tumor, a blood tumor, a brain tumor, a breast or lung or liver or whatever. So we think that is a core principle. And with respect to sort of stage, when patients are first diagnosed, I think that's the best opportunity, of course, and earlier diagnosis, the best opportunity to help patients live a much longer life. So the earlier we can get to patients and use this treatment alongside standard of care, I think that is better. But all the time, patients are able to mount an immune response or able to take standard of care. I think we have a potential part to play. There are, of course, the many very sad situations that you get to where a patient right at the end of their life, our doctors have to make the call, I'm sorry, I think this is now too late. And that's obviously a difficult discussion to have with patients. It's a common one too. But the earlier we can get patients, the better, and across all cancer types, actually.
How much of a positive effect is the clinic having? Can you tell?
So, the only way of really telling that is to conduct studies. And, when I looked at all the literature, there's a vast amount of literature saying that these things have a positive effect in cancer. That there was a small study here or a larger study there or an epidemiological study somewhere else. So there's a lot of data to support their use in cancer, but there was not a definitive test. And the way that people talk about definitive tests these days is a placebo random controlled clinical trial, a placebo RCT, and there wasn't one on this protocol, but there is all that vast amount of information available. But nor will there ever be one on this protocol, because it's a complex protocol. We're trying to multiple interventions on metabolic pathways. If you wanted to do a placebo RCT on this protocol, it would be prohibitively expensive, even for a major pharmaceutical company. But nevertheless, we wanted to publish results. And we started to look at, and this is what we've done already, started to look at ways of being able to publish these results in a way where the oncology community can start to believe that these are meaningful clinical studies. We did not want to just put out into the scientific literature yet another study that is not helping people to come to conclusions about the viability of these treatments. We wanted something a bit more definitive. And we've made our first steps at that, actually. Recently, we published our first preliminary report of glioblastoma, which is a very, very aggressive brain cancer. And we can publish this. Obviously, it's done under the guidance of our regulatory authorities, but we can publish this because, rather sadly, the prospects in glioblastoma are rather grim. And it is a population that's relatively easy to report upon because of that sad feature. And what we showed in this preliminary analysis, which we're going to continue with, is that the standard of care historically has given us 14 months in this patient group as an average life expectancy. And what we saw in our preliminary clinical write-up here, looking at historical controls, is a 28-month life expectancy, which is absolutely an enormous increase when you consider what happened when the standard of care chemotherapy was introduced, I think about 20 years ago, which is a drug called temozolomide. What happened there was standard of care was simply surgery and radiotherapy, and it went up from the 12 months to the 14 months that temozolomide could give people. And that was greeted, in spite of the side effects of the drug, as a very significant breakthrough. So you can see how excited we would be with potentially adding at very low additional side effect burden, almost a 100% increase in life expectancy. So, we're trying to publish, we're trying to change the baseline here. Our vision would be, can we get a protocol like this to patients as early as possible? Can we get it to these patients such that they can all afford it wherever they are in the world? And can we do that as early as possible? And we're trying to publish our way into that, in a sense, because that's the only way I think that the clinical oncology community will adopt this sort of metabolic profile program.
Do you have any significant number of outliers, people that live 3, 4, 5 times what's expected?
I'd have to go and inspect the data, but there are always those in all cancers. Actually, oncologists over here say to me, when we first started talking about that, I'm not interested in seeing a few patients and some of them surviving for a very long time. We all have our miracles, is said. And of course, happily that is so, especially for those patients. That's why you really need to do proper statistical studies. And that's what we're doing. So within that, yes, there will be those that are living longer and those that are living shorter, but it's the statistics of the study that will deal with those effects.
But are you observing a lot of miracles? Or can you even say? Are you suspiciously thinking, we're getting a lot of miracles here? Or is it not like that? It's just longer?
I think, Richard, what we are seeing is an elongation of patients' lives. I think and I think that's what we've seen in the glioblastoma group. I think that's what we saw with my wife. She got an extra 4 or 5 years that she would not otherwise have had, and that was a great thing for us. No, I think what we are doing is an incremental step forward. This isn't a cure for cancer. It's an incremental step forward. We are helping patients, I think, get a better life expectancy than they would otherwise have. And I think they're getting that at a very marginal effect upon side effect burden. Certainly they don't have additional side effects like chemotherapy and so on. So I think that's what we are. I think that's where we are going to see this approach lie eventually, but it is going to be something that in the fullness of time should be very readily available to everybody. It should be available at diagnosis. It's not going to be something that will be restricted to those people that are wealthy. I think it has a tremendous potential in that way. A friend of mine describes this, instead of it being a moonshot to treat a cancer cure, this is a ground shot. This is an incremental step forward where we can do something significant to help patients right now.
Well, that's still an excellent thing. So, Robin, what's the best way for you? Only work with people in the UK, or do you have clinics in other countries yet, like the US? What's the status?
So there is. Yes, we do. Yeah, we do. We set up in the UK initially. We set up in London as a clinic that people would visit. We quickly became aware that people actually wanted to do this via video consultation as well. We do have patients around the world actually that we can try and help and advise upon. And it was, I think, last year that we set up Care Oncology in the US. So there's a US website as well as a UK website. So these are the two first territories that we have presence in within the territory, so to speak. And people in both those territories can easily access the Care Oncology protocol, but most importantly, the medical oversight and the medical supervision that goes with it. Because remember, these are complex, difficult patient situations that requires the medical oversight in order to properly manage patient safety. And I think that's one of the things that makes us attractive to people, actually. People know they want to do something additional, but want some medical oversight in doing so. And I think that's what we're providing for the Care Oncology protocol, both in the UK and in the US. That's
excellent. Well, Robin, so the best way is what website? How do people find out? Just Google it?
So the US website is www.careoncology, and for the UK, it's www.careoncologyclinic.com. Both .coms. And there's lots of information on those websites, actually. And that's one of the things about these drugs. They're such well-known drugs. And I often say to people, if you want to find out about these drugs, and they often do, I say, well, go and find out about them yourself. All of this information is available. You know, we've distilled it, we've put it into a protocol, but you are able to go and see this information yourself and make up your own mind about prospects and how they might be changed. And a lot of that information is on those websites. You know, there's the source information, the information that I used all those years ago to start to think that maybe we can do something positive in cancer.
Well, that's excellent, Robin. Thank you for coming on the podcast. I really appreciate it.
A pleasure.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.